Go to the next talk by Dr. Biju Raju. Dr. Biju will be speaking on some salient features, pearls in the management of, the interpretation of OCT. Over to you, Biju.
Thank you very much. I have no financial disclosure to be made. My first pearl on OCT would be to know your scan and never to rely on a single scan, and also to rely more on the grayscale than the false color code of the image. And if you are going to rely on a single printout or a single scan of the OCT, then you are missing out a whole lot of things on the retina. As in this case, we would think this is a maculopathy with a subfoveal serous retinal detachment. You might plan injections, but this is actually a macular hole. But why did that happen? Because the scan line actually goes above the macular hole, which gives you this impression, whereas this is what is actually the condition of the patient. So be very careful when you interpret images with just one scan. It's not the proper way to do. You might end up in trouble. And OCT is essentially a representation of the reflected light, the intensity of the reflected light. And the grayscale is actually the intensity in levels of the brightness. So which makes it an ideal way or a mode to look at the kind of layers and changes in the retina with OCT. When you have color, it's a false color coding, and they have color hues for the different brightness. And that makes for lesser contrast sensitivity, and color distracts your perception and you miss certain textures. Studies have shown that grayscale images are far better in evaluating OCT scans. And when you look at this picture here, you can see that once the color is gone, the layers just pop out, and it's very easy to identify the different layers. My second pearl would be to see the layers. When I say see the layers, I would say see through the layers and see beyond the layers, because we all know what the layers of the retina are and how they appear on OCT. But we should understand that they are all reflectivities, and the bands that come on OCT can be correlated or cannot be correlated certain times with histopathology. For example, when you look at the ganglion cell layer, it's a hyporeflective layer that is well correlated with its counterpart on the histopathology slide. But when you take the case of ellipsoid, which is packed with mitochondria, we would think that the line, one of the lines in the outer retina, is the ellipsoid. But still there is no consensus. We don't know as of now whether that line is caused by these mitochondria containing ellipsoid zone. So they are parts of the retina which we don't have a clear correlate when you look at the histopathology. So they are divided, these layers are divided into bands and zones. When you have a clear-cut evidence, a clear-cut layer with a clear-cut evidence on histopathology, we call them bands, which are well defined, and which don't have a strong correlation histopathology, like the ellipsoid, you call them as zones. And as a general rule, all cellular layers are hyporeflective, and all synaptic and nerve fiber layers are hyperreflective. So it's no surprise that when you look at the hyperreflective band, all the synaptic layers and the nerve fiber layer, along with RPE, of course, with the melanin, is hyperreflective. They are the bands. And the hyporeflective band, as you guessed, it's all the cellular layers of the retina. And the zones, the hyperreflective zones are the ellipsoid and the interdigitating, and the hyporeflective being the myoid and choriocapillaries. These are layers on the retina. We clearly don't have a clear-cut idea what is actually contributing the band on the zones in the retina on OCT. So this is a summary of the facts that I just mentioned, and this is well described in the article by Dr. Munna Bende in Indian Journal of Ophthalmology. My third pearl would be to look for the biomarkers. In OCT, there are two biomarkers, but two classification of biomarkers, that is the fluid biomarkers and the structural. The fluid being based on the distribution of the fluid in the retina as intraretinal cyst, subretinal fluid, and sub-RPE. We know that intraretinal cyst or fluid are more dangerous than the subretinal fluid, which some authors say are protective to the status of the retina. So when we know the level of the fluid and the status of the fluid level, fluid in the retina, we know that you can have a prognostic outcome. We can prognosticate the outcome after treatment of those patients. And The structural changes could be retinal or choroidal, and these are the few of the retinal biomarkers. We can see the drill, which is having a poor prognosis, the double layer sign, which can say that there will be more exudation, but they can respond well, and integrity of the photoreceptors based on the external limiting membrane, ellipsoid, and the interdigitating zone. So the damage occurs in this direction, and when they start recovering, the ELM comes first, then the ellipsoid and the interdigitating zone. When you have PEDs more than 550 microns, you have to be careful, and if it is especially a fibrovascular PED, then there's a high risk for retinal pigment epithelial tears, which can lead to a poor vision. And the choroidal biomarkers, we are getting to know them better, but we all know about the choroidal thickness, which is important to identify pachychoroid syndromes. So when you look at the summary of these factors, most of them are poor prognosis factors. When you look at that and see them in the scan, you know that the outcome is not going to be very good. But certain things are of good prognosis also. And the photoreceptor integrity guides you on how the visual improvement is coming through. These are my 3 pearls on interpreting OCT scans. Thank you very much.